Hello and welcome everyone to the 2025 ACT Health Update on influenza and winter respiratory illnesses. Tonight we'll be focusing on influenza and RSV infections and their respective vaccination programs. I am Dr. Leonie Harcourt, a GP advisor at the Capital Health Network. Also with me tonight are Kunal Mohiti, the events lead at Capital Health Network, and of course our speakers. Pediatrician Dr. Jean Li-Kim-Moy from Sydney and Dr. Megan O'More, a public health doctor from the ACT Health Directorate. So first, we would like to acknowledge the traditional custodians of the land we are meeting on, the Ngunnawal people. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. We also acknowledge and pay our respects to any other Aboriginal and Torres Strait Islander people who may be attending today's event. And just a quick flag for Health Pathways. Health Pathways has management guidelines and referral pathways for common conditions such as influenza and bronchiolitis. Housekeeping. All participants have been muted. Please type any questions you have into the Q&A box on the Zoom panel, not the chat box. And we'll have we've planned to have a fairly long Q&A session at the end because we think there will be quite a few questions. But if we don't have time to answer your question, please email immunisation@act.gov.au and your questions will be answered that way as well. Thanks very much. And so over to our presenters. So our first presenter is Dr. Jean Li-Kim-Moy. John is a senior medical officer in immunisation and a paediatrician at the National Centre for Immunisation Research and Surveillance in Sydney. He's also a clinician working in community general paediatrics. He joined NCIRS in 2011, so quite a while ago, working as an investigator in numerous vaccine trials, and he completed a PhD in 2018 on influenza vaccination in Australian children. He's an adjunct senior lecturer at the University of Sydney and currently works in the policy team at NCIRS and leads their RSV and zoster vaccine teams to provide technical support to the Australian Technical Advisory Group on Immunisation, ATAGI. So over to you, Jean. Thank you very much.
Thanks, Leonie, and thank you for asking me to talk today. So I'm going to talk about prevention of RSV in infants with the maternal vaccine and monoclonal antibodies. So I too would like to acknowledge the traditional owners of land on which we meet, and for me, that's the Gadigal people of the Eora Nation, and to pay my respects to elders past, present, and emerging. So just a little bit of an outline of the talk, what I'm going to be talking about. So I'm just going to start off by giving a quick recap on RSV epidemiology, to then move on to the RSV prevention products, the vaccine, and the monoclonal antibody, which are used to protect infants. So I'll talk a little bit about how they work, about how well they work in terms of their efficacy and effectiveness, and then also talk about some of the safety data and any safety concerns. I'll go through some of the recommendations for their use, including the high-risk groups they should be used in, and then finish off by talking about some practical tips and some common questions that have come our way. So firstly, talking about the burden of RSV disease in infants. And this study looked at the global burden of disease in children up to 5 years of age. And we can see that there is quite considerable burden. There's 33 million episodes of severe respiratory infection each year, causing 3.6 million hospitalizations and about 100,000 deaths. And you can see in the pink portions of this pie chart that when you're looking at particularly the youngest children, aged less than 6 months, that proportion, particularly in the more severe outcomes such as death, is much larger. So in total, RSV accounts for around 3.6% of global child mortality, But it's important to note that a large part of this burden is borne in low and middle income countries. So more than 97% of these deaths are seen in low and middle income countries, and death is very uncommon in high income countries such as Australia. So when we do look at places such as Australia, who gets RSV? So RSV is a universal infection, and most children by 2 years of age will have been infected at least once. So there's this famous study, the Houston Family Study, conducted in the 1970s, which prospectively followed 160 children and tested them frequently, looking for RSV infection, including by serology. And what they found that by 24 months of age, 2 years, 97% of children had already had their first RSV infection. And by 3 years of age, pretty much that figure was 100%. When we look at severe disease in somewhere like Australia, we're mostly talking about hospitalization. And you can see in this graph here on the right, which looks at RSV-coded hospitalizations in children under 5 years of age. You can see this peak exists in children, particularly those less than 6 months of age. And in fact, about 1 in 50 children will be hospitalized with RSV during their first year of life. And the majority of those children will otherwise be healthy. So when they do acquire severe RSV infection, often this presents as bronchiolitis, which causes feeding difficulties and respiratory distress and wheezing in infants. They may need to come into hospital to receive respiratory support in terms of oxygen, feeding support, including intravenous fluids, and particularly in even more severe cases, they may end up in ICU with ventilatory support. And there are also longer-term effects from RSV, which is thought to play some role in the risk of wheezing and asthma in later life for infants. When we look at the risk factors for hospitalization, these are some graphs from a Scandinavian modeling study, and you can see it gives certain clues as to who are more at risk of hospitalization. So in this graph here, and the top one on the right here, sorry, in the middle, you can see gestational age. So prematurity, in particular, you can see the more premature you are, the higher the rate of the risk of hospitalization. Additionally, the age and timing of birth in relation to the RSV season, you can see this graph here showing an increased risk, particularly obviously under 6 months of age, but it's peaking, if you're born just before the RSV season, because you're much more likely to meet RSV if you're born just before the season. Again, that increases your risk for hospitalization. And over here on the right, you can see certain medical conditions, including congenital heart disease, respiratory conditions, and Down syndrome can also increase your risk, as well as some social factors, such as living in a household where there are other siblings younger than 4 years of age who may bring RSV into the household. So what we can see is in this study of RSV deaths over 20 years conducted at a tertiary pediatric hospital, we can see that all the children who died from RSV had a medical comorbidity. Median age was just over 2 years. And when we're looking at other conditions which they have a lot of conditions which we are going to see in the list of risk conditions for severe RSV. They include things such as neurologic conditions, genetic conditions, respiratory disease, prematurity, immunodeficiency, congenital heart disease. So this brings me to the RSV immunisation products to help protect infants. I'd just like to start with some basic terminology because some of this may be a little bit new to some people. So we talk a lot in terms of preventing infants getting unwell about using passive immunisation. So what is passive immunisation? That's protecting somebody through the provision of antibodies. And those antibodies can either come from the mother across the placenta, or it can come from an injection of a monoclonal antibody directly into the infant. And this contrasts with active immunization with a vaccine. And that a vaccine, as we know, relies on introducing an immunizing agent into somebody's arm. And that can be a protein, an mRNA fragment, or even an organism or a weakened virus. And that stimulates the person's immune system, and their own immune system is what produces the antibodies and the cellular immunity. So when we use a monoclonal antibody, it's a preformed antibody within that syringe, and that's injected, and it's directed towards a specific target. It can be given as an injection or sometimes as an infusion. And we're starting to use the term immunization product to be able to refer to both vaccines and monoclonal antibodies. So how do these immunization products work? So they target the RSV F protein, which is on the surface of the RSV virus. And it basically is the fusion protein. It helps the virus to fuse to respiratory cells. And what happens when the virus fuses is that F protein changes shape. And the breakthrough with these modern products is that they have been able to target just the pre-fusion form of the virus. So both the RSV vaccines and the monoclonal antibodies are directed towards the pre-fusion F protein. That F protein is similar between RSV A and RSV B subtypes, and also relatively well conserved so that different strains of RSV, the F protein doesn't change very much. So nirsevimab, which is the monoclonal antibody, targets this red section here, the site 0, and it's substantially more potent than the previous monoclonal antibody, which we had called palivizumab, and also has the benefits of being long-acting, so it lasts for a whole season with only one injection. So again, we talk about providing passive immunity, and that can be through active vaccination of the mother, who then creates an immune response with antibodies that are then passed through the placenta, or through directly giving monoclonal antibodies to the infant. So we've got the available products here. Abrysvo is the one that we're using in pregnant women. There is the other vaccine called Arexvy, which is not licensed for use in women, in pregnant women. And there's Beyfortus, also known as nirsevimab, which is the monoclonal antibody given directly to the infant. And clesrovimab is another long-acting monoclonal antibody, which is on the horizon and should hopefully also be available in the next few years. So the RSV mother and infant prevention program is now underway, and we need to look at it as having two complementary components or parts. So there's maternal vaccination, as we've said with Abrysvo, and that is funded through the National Immunisation Program and is available for all pregnant individuals, including those who are aged less than 18 years of age. And on the right, we have long-acting monoclonal antibodies for infants with Beyfortus or nirsevimab. And that currently is funded by separate state and territory programs for some infants. So the way that we look at that are two distinct opportunities to protect an infant. So the first opportunity is targeted at the mother, at pregnant women, using a Brisvo vaccine from 28 weeks of age, 28 weeks gestation, aiming for at least 2 weeks before the birth. The second opportunity to protect is for those is directed at infants, and it's for those infants whose mother was either unvaccinated or who was vaccinated less than 2 weeks before giving birth. It's also targeted at certain infants with risk conditions which increase their risk of severe RSV, even if their mother was vaccinated, and also infants who may have lost some of their RSV antibodies to restore protection against RSV. And so that's using nirsevimab, and is given to infants at birth, prior to or during the RSV season, or for older children prior to the RSV season. Importantly, if an infant is healthy with no risk conditions and the mother's appropriately received RSV vaccine, they shouldn't require nirsevimab because they should be adequately protected just from the maternal vaccine. So importantly, in terms of catch-up for high-risk children, so the program with maternal vaccination started, I believe, on the 5th of February, and the nirsevimab program in New South Wales and ACT started on the 17th of March. So for high-risk children born prior to program commencement in the ACT, they've still been able to be protected through the Vulnerable Babies program, basically targeting those who were, had prematurity less than 37 weeks at birth, First Nations infants, and those with the high-risk conditions listed in the handbook. So New South Wales had very similar guidelines, but just at the end of last week, they announced that they would be expanding their guidelines such that their eligibility for standard and high-risk infants would be for anyone born from the 1st of January 2025. So they're still having catch-up for high-risk infants under the Vulnerable Babies program from 1st of October, born 1st of October 2024 to 31st of December 2024. So this slide is outlines the risk conditions for which infants may require nirsevimab, even if their mother has been vaccinated. And the best way is to really use this flow chart that's on the right-hand side here. So we start by asking, has the mother been vaccinated with a Brisvo more than 2 weeks before delivery? And if they haven't, so either from being unvaccinated or the baby being born less than 2 weeks after the mother was vaccinated, then we consider them not to be adequately protected. And so the infant should receive nirsevimab at birth. However, if they have been vaccinated appropriately, then we ask this additional question: is there additional risk to the infant whereby they might need nirsevimab as well? So this is this list is of the risk conditions which we've outlined here on the left. So preterm birth less than 32 weeks, congenital heart disease, significant immunosuppression, chronic lung disease, neurologic disease that impairs respiratory function, cystic fibrosis, or trisomy 21 and other genetic conditions associated with an increased risk of RSV. We also asked you, there may be a separate population of infants, a very small population, who might have have been born to mothers who had severe immunosuppression at the time that they were vaccinated, and potentially they may not have had a good response to the vaccine. Or they may have had a procedure such as cardiopulmonary bypass or ECMO, whereby these particular procedures can sometimes lead to a loss of protective antibodies. So if either of these conditions are met, then they may require additional nirsevimab. But if neither of these apply and the mother's been appropriately vaccinated, then this is the infant who doesn't require any additional protection, so is not recommended to have nirsevimab. So in addition, there's the recommendation for second season. So that's directed for infants who are 8 to 24 months of age who continue to have or develop some of those risk conditions that we outlined in the previous slide. And so they're recommended to have nirsevimab prior to their second season, noting that in most temperate regions, including the ACT, the season will be from approximately April through to September. So they do, however, need a higher dose for the second season of 200 milligrams, and it is given to the infants just prior to the RSV season, with the recommendation being that there's a 6-month interval between any first season dose and a second season dose. So it's important with the dosing to understand the first season dosing is by weight. So less than 5 kilos is 50 milligram dose, and 5 kilos or above is 100 milligram dose. And you can see the two preparations which have different color coding for the different pre-filled syringes. For the second season, it's a fixed dose of 200 milligrams. And unfortunately, nirsevimab only comes as 100 milligram pre-filled syringes. So that would mean that for a 200 milligram dose, it would be 2 separate injections at 2 different sites. And noting that as per standard immunization handbook guidelines, injections can be in the deltoid once babies are more than 12 months of age. So this slide is just to indicate that these are the nirsevimab programs are run by states, and the states have slightly differing eligibility. So ACT and New South Wales are running their program year-round, while some other states are doing just a seasonal program. Victoria and WA have included First Nations children as a risk condition for second season. So there's a good summary of the different states and territories programs available on the NCIRS website, and you can scan this QR code to go there. It just hasn't been updated with the very recent New South Wales eligibility just yet. So just to talk about how well do these products work and are they safe? So with Abrysvo, so that Abrysvo is a bivalent prefusion F protein vaccine, and it's recommended for women in Australia from 28 weeks gestation, and it's a single dose. So the pivotal clinical trial, you can see results from that underneath here. Different outcomes measured. So this is RSV, lower respiratory tract disease, severe RSV, lower respiratory tract disease. And you can see this separation between placebo and vaccine groups. And it's showing good efficacy as high as 82% for severe lower respiratory tract infection due to RSV in the first 90 days. If we look at hospitalization, it's the vaccine efficacy all the way out to 180 days has been 57%. When we look at the pivotal trial safety data, what we can see here, we can see comparing the vaccine with the placebo groups. So for most of these things, there isn't any significant difference between the vaccine and placebo groups. So most mothers didn't experience any adverse events, and the adverse events which they experienced were mild, with typical pain and fatigue, often the most reported amongst mothers. There was a small non-statistically significant difference in preterm births, which I'll talk about in the next slide. In terms of the infants, and again here are the infant adverse events, and again you can see very similar between the infants who were born to mothers who were vaccinated and infants who were born to mothers who received placebo. Most commonly reported serious adverse event was neonatal jaundice, and none of this serious adverse events were thought to be vaccine related. So you may have heard some talk about preterm birth and RSV vaccines. So the question is, why is there discussion of this? Again, it comes back to this pivotal clinical trial. And what you can see here is on the left is what they found was that there was 5.7% rate of premature birth in the vaccine group versus 4.7 in the placebo group. Now, clinical trials aren't powered to detect all rare occurrences, and at this frequency, the rates were still thought to be not statistically significant, so they could still have occurred by chance. When they looked at it in more detail, particularly in high-income countries, as you can see here, there was no difference between prematurity rates in the vaccine and placebo arms, and these high-income countries were where most of the participants were in the trial. What seemed to cause most of this difference between vaccine and placebo groups was upper middle income countries. And again, there wasn't a significant finding in low income countries. And when they separated out the trial sites, it seemed to mostly be in South Africa that they were finding this increase in prematurity in the vaccine arm. Interestingly, that it coincided in terms of when these premature births were occurring. It coincided closely with the Delta COVID-19 wave, and so they did look very carefully to see whether COVID-19 vaccination or COVID-19 infection was associated with the prematurity, and they weren't able to show that that was associated and explain what was seen in South Africa. So it may be, some sort of complex association with what was going on at the time and potentially affecting, antenatal care and access to hospitals. It's not quite clear. But importantly, infant deaths were no different in the groups. In fact, it was lower in the vaccine group at 8 than in the placebo group at 14. Post-marketing studies have been conducted in the US, one of the countries where they've had widespread use of the vaccine. And so far, they've been reassuring. This study was an observational study comparing prematurity rates in women who were vaccinated, matched to unvaccinated women. And as you can see, no difference between the prematurity rates in vaccinated versus unvaccinated women, in fact, slightly lower in those who were vaccinated. The one caveat is that obviously this was in the US, it's one country, and the US has been adopting a slightly more conservative gestational window of vaccination between 32 and 36 weeks gestation compared to 28 weeks here in Australia. But importantly, the UK recently started their national program slightly earlier than ours, since September of last year, for the 24-25 season. And so far, we've not heard of any concerning reports or any safety signals around prematurity coming from the UK. So in terms of nirsevimab, the monoclonal antibody, the clinical trials with nirsevimab again have shown very high efficacy, up to 81% in terms of protection against hospitalization to 150 days. Nirsevimab has also had widespread use in the real nationally. Real-world evidence suggests that the effectiveness is very similar to what was seen in the clinical trial. So in Spain was one of the first countries to recommend it and to fund it nationally. And they are now into their second season of using nirsevimab and achieved very high coverage rates of sort of 90% or more of young infants receiving nirsevimab. Here is the median hospitalization across a season in a typical year. And the orange line was the first season that they started giving nirsevimab, and the bars are the second season. And as you can see, marked differences in the hospitalization rate for young infants due to RSV once nirsevimab was available. Expressed differently, this is the cumulative number of hospitalizations across the season. As you can see, the typical RSV seasons, and then the marked reduction once nirsevimab was rolled out. And in fact, studies have been conducted about the real-world effectiveness in multiple locations across Europe, South America, US, and Australia, and they're all showing very, very similar figures. The purple figures are vaccine effectiveness against hospitalization. So WA has just published its data showing 88.2% effectiveness against RSV hospitalization in their first season. They've also published safety data on their use, and again, very reassuring figures for safety of nirsevimab with no serious reactions and only 1.5% requiring medical attention after receiving nirsevimab. And in fact, if we look at their figures for local reaction at 2.3% and fever at 3.4%, you can see compared to the data from AUSVAC safety, looking at standard 2-month vaccines, looking at the blue bars here where the vaccines are given by themselves, you can see that the reactogenicity of nirsevimab, in fact, is probably a quarter to a third of what we're seeing with typical 2-month vaccines. So very well tolerated. And the important thing with use of immunization products like nirsevimab is it doesn't appear like it's simply shifting severe infection to the second season or second year of life. So this study looked at following up those children who had received nirsevimab in the clinical trial, and in the second year of life there wasn't a significant difference in RSV lower respiratory tract infection between those who were in the nirsevimab group and those who were in the control group. The infections that they had in the second year weren't worse in those who'd received nirsevimab. And also importantly, they also looked for post-F antibodies, which suggest an immune response to natural infection. And what they found was that these post-F antibody responses were, again, similar in both infants who'd received nirsevimab and infants who hadn't, suggesting that whilst nirsevimab might prevent severe infection and hospitalization, it's still allowing the children who have had it to get subclinical or mild infection and develop an immune response for later infections. So just finishing off with practical tips and common questions that we have been answering. So to providers, I'd encourage you all to encourage mothers to take up maternal vaccine at the appropriate time and not to wait for nirsevimab. So we know both Abrysvo and nirsevimab offer very good protection. And we know, as from the data that I've presented, that Abrysvo vaccine is safe, and that post-marketing studies don't show any increase in preterm birth so far. We would say that declining a vaccine in pregnancy means a missed opportunity for protection. And there could always be issues with sourcing nirsevimab or getting the baby vaccinated or immunized with nirsevimab at birth, which could mean that they miss out on protection for a period of time. In addition, nirsevimab does mean a third injection for babies at birth, and for some parents that is a concern. So many would prefer to get the vaccine earlier on in pregnancy. So maternal vaccination will be the cornerstone of the program. It'll continue to be nationally funded, while nirsevimab, we're going to need to continue to watch and wait each season to see whether the states and territories are able to secure funding for that. Importantly, evidence of gestational age is not required to receive the maternal vaccine. Simply asking the mother where she is verbally in terms of her pregnancy is enough to guide if it's appropriate to vaccinate her at that time. So around documentation is going to be very important. So we encourage all providers to make sure they're recording all maternal and infant immunisations on the Australian Immunisation Register, as well as other locations that might end up being checked. So that includes the yellow antenatal card, as well as the baby's personal health record, or Blue Book as it is in New South Wales and ACT. Because when a mother presents to delivery suite, it'll be important to check whether her infant will require nirsevimab. And that can be done by checking the mother's air record, either through a printed vaccination history, by asking her to check on her Medicare or MyGov app, looking at linked electronic medical records if vaccinations are recorded there, or looking at the antenatal health record. Importantly, once babies are born and if they receive nirsevimab, they don't need a Medicare number to have their immunisation recorded, similar to other birth doses. And for infants seen after birth, it'll be important to check their eligibility by looking at the maternal and the infant air records to see whether they've received the mother's either received maternal vaccine or the infant's already received nirsevimab at birth. So co-administration is acceptable for both products. So Abrysvo can be given in pregnant women, co-administered with other pregnancy vaccines, including Boostrix, flu, COVID-19, as well as anti-D injections. And nirsevimab can similarly be co-administered with other infant vaccines and injections, including hepatitis B vaccine or immunoglobulin and vitamin K injections. In terms of some eligibility questions we've been asked. So can pregnant women be vaccinated even if they've passed 36 weeks, there's 37 weeks gestation? And the answer is yes, as long as you're not expecting them to deliver imminently, such as the planned cesarean. And yes, it remains free under the National Immunisation Program. Pregnant teenagers, as I've said, can receive Abrysvo. It's not against the product information. But Abrysvo is not to be used for active immunisation of children to protect the child. Abrysvo does require a Medicare number as it is part of the NIP. But for anyone who doesn't have a Medicare number, states and territories have committed to funding nirsevimab for all eligible infants, regardless of their Medicare status. So it's also important to make sure that we are giving the correct product to avoid inadvertent administration of the wrong product. So Arexvy is a vaccine that's only registered for use in older adults, not pregnant women. So avoiding giving it to pregnant women is important. Similarly, Abrysvo is for pregnant women and shouldn't be given to infants. And nirsevimab is only for infants and shouldn't be given to a pregnant woman. If there's any inadvertent administration, report it to your local health authority, to the TGA, as well as following clinical guidance. And that clinical guidance is in the form of some guidance on RSV immunisation product administration errors. And that, again, is available on the NCIA's website through scanning here. It gives important information what to do with RSV vaccine being given too early, too late, the wrong dose being given, the wrong product being given, or compromised products being administered. My last few slides, fun way to remember what to give. So Abrysvo sounds like embryo. The B also looks like a pregnant woman. So remember, Abrysvo is for pregnant women, but Arexvy has the last few letters of the alphabet, X, V, Y, and only for older adults. Again, a plug for the NCIA's immunisation resources. We've got a page which lists all the important resources, including frequently asked questions, the clinical guidance on errors, state and territory programs, and some of the clinical trial data that I might have gone over today. So to conclude, the program is now underway. Abrysvo should be looked as a first opportunity to protect infants, with nirsevimab as a second opportunity in selected infants, and also to protect high-risk second-season children. Both products are safe and highly effective. We are monitoring for adverse events of special interest, including preterm birth, but so far, the data has been very reassuring and hasn't raised any concerns. So ensure that correct products are used and ensure that there's adequate recording of all doses. So I might finish there and be happy to answer questions at the end of the session.
Thank you, Jean. That was really interesting, and it'll be very interesting to see what the paediatric ward at Canberra Hospital is like this winter and in subsequent winters. It sounds so it's quite promising. So just a reminder, type your questions into the Q&A box. We'll have the Q&A session at the end of the Megan's presentation. And also, if you think of a question afterwards that you forgot to ask tonight, the ACT Health Immunisation Group is very happy to field questions. So the email address for that is immunisation@act.gov.au. So now over to Megan, who's going to talk a little bit more about RSV in older people and also about influenza. So Dr. Megan O'Moore is a public health advanced trainee registrar in the ACT Health Directorate in Canberra. She has public health experience in national vaccine pharmacovigilance, surveillance of adverse effects following immunisation, and medical device regulation through her previous work at the Therapeutic Goods Administration. So over to you, Megan. Thank you.
Hi, everyone. Can you see those slides okay, Leonie?
Yep.
Great. Okay, thanks for taking the time to join us in this webinar tonight, everyone. I also just want to echo that thanks to Dr. Jean for an excellent presentation on RSV, which has really nicely set the scene for the second half of tonight's webinar, where I'll be talking about this year's vaccine program updates in the ACT relating to winter respiratory illnesses. I'd also like to begin by acknowledging the traditional custodians of the beautiful land that I'm coming to you from, and that's the lands of the Ngunnawal people. And I also recognise other people or families that have connections to the lands of the ACT and to this region. So to give a bit of an overview of what I'll cover in the next half an hour or so, we'll start off with the 2025 RSV prevention program, looking at eligibility and logistics in accessing stock. We'll then move to the 2025 influenza vaccine program, firstly looking at the 2024 influenza season, and then the recommendations and the priority groups for this year. We'll also briefly touch on other vaccine products that are available that could be considered opportunistically when you're seeing patients for an influenza vaccine, so specifically COVID-19, pneumococcal, Shingrix, and RSV vaccines. We'll provide some take-home messages, and we'll also have some useful resources that you can refer to in the future. So starting with RSV prevention. Just to recap, as Dr. Jean has already covered, there are currently 4 RSV prevention products that have been registered in Australia. So these include the 2 monoclonal antibodies, there's the shorter-acting palivizumab and the longer-acting nirsevimab or Beyfortus. And then there are also the 2 RSV vaccine products. There's Arexvy, which is only registered for individuals who are over 60 years of age, and Abrysvo, which is registered for individuals who are over 60 and also for pregnant people. And just a reminder again that there are no RSV vaccines that are approved for use in children. For a bit of context about RSV prevention in the ACT, in 2024, states and territories provided funded Beyfortus, and in the ACT that was done through participation in the New South Wales RSV Vulnerable Babies program. So this program saw the provision of Beyfortus to babies and to infants who were up to 2 years of age that were at risk of severe RSV disease. And this was provided through various hospital sites in the ACT, and it ran through to the end of September 2024. So off the back of that program for 2025, the ACT has an RSV prevention program which is targeted at protecting infants and young children against RSV. And this is being done through those 2 arms which Dr. Jean has spoken about. Firstly, there's the provision of the antenatal RSV vaccine, which is Abrysvo, and also through the provision of a monoclonal antibody, which is Beyfortus, and that's for eligible infants and for young children. So the first arm of this program, antenatal vaccination, it's being provided through the National Immunisation Program. So from the 3rd of February this year, all pregnant people that are between 28 and 36 weeks gestation are offered Abrysvo at antenatal visits. Although Abrysvo is registered from 24 weeks gestation, its administration in that 24 to 28 week window is not currently recommended until there's some more safety and efficacy data. So the target window at this point is administration from 28 to 36 weeks. It's administered via a single intramuscular injection, and it can be given with other vaccines provided in pregnancy, such as pertussis and influenza vaccines. And it can be administered at any time of the year, so it's not dependent on the month or the season. At this stage, subsequent pregnancies are not yet recommended to receive further Abrysvo, and advice on potential repeat vaccination during subsequent pregnancies is expected to be provided in the future as more data becomes available. You'll probably all be aware that Abrysvo stock began being distributed to immunisation providers earlier this year, and that stock rollout has continued, and there's been over 800 doses of Abrysvo administered to pregnant people in the ACT so far this year. So that shows that you're all doing a really great job of communicating and actioning the rollout of Abrysvo already. So thanks to all of you that have been involved with that. Like other vaccine products, the process for Abrysvo is the same in terms of ordering stock online, and that's likewise for reporting suspected adverse events following immunisation, as well as reporting medication administration errors. And it's always important to ensure that you're administering the right product to the right person at the right time. And in the case of Abrysvo, it's important to check that you're administering Abrysvo to pregnant people between those 28 and 36 weeks gestation. There are some great ways to remember which RSV vaccine is for which cohort, and this one, which Dr. Jean has also mentioned tonight, is quite useful and memorable, and it's courtesy of Dr. Sonia Annis from New South Wales Health, and she shared this at the NC's RSV webinar in February this year. And that webinar actually is another great resource if you have the chance to review it. We've already touched on it, but Abrysvo sounds like embryo, has the letter B in it, which might remind you of a pregnant belly. And to try to further distinguish Abrysvo from Arexvy, you can see Arexvy, the letters XVY in it, which is at the end of the alphabet, and that can correlate to older people at the other end of the lifespan, so in that over 60 years cohort. So Abrysvo sounds like embryo, has the letter B in it for the pregnant belly, so for pregnant people, and Arexvy, XVY, relating to the older age cohort, which is for older adults. So hopefully that helps you to remember and reduces the risk of some RSV vaccine administration errors. But of course, if they do occur, please report them through to the ACT Health Immunisation section. And we have a slide later in this presentation that has some information on how to do that, which we'll go through and you can refer to it in the future. Another important thing to remember, particularly with Abrysvo, is that as of the 1st of March, it's now mandatory to report information about whether an individual was pregnant at the time they were vaccinated. So this is really important to enable monitoring of immunisation coverage in pregnancy, and also to look at the safety of maternal vaccines, as well as the effectiveness of maternal vaccination programs. So to do this in AIR, you can use either the antenatal indicator, which is a new field that will be rolled out in clinical software this year, and that gives you a yes, no, or unspecified options, as you can see on that screen grab. Or you can use the existing vaccine type field, and then you can select the antenatal option. So jumping over to the other arm of the ACT's 2025 RSV prevention program, which is the monoclonal antibody Beyfortus. So this is being funded by states and territories, specifically for infants and for children who are up to 2 years of age. So the ACT program is based on evidence and advice from ATAGI, and it aligns with the New South Wales RSV prevention program, although there's some eligibility and implementation differences between the jurisdictions, but the ACT program is evidence-based and it's consistent with the national recommendations. So Beyfortus is being supplied at public and private birthing hospitals. It's also being provided for catch-up and second season doses through Canberra Health Services clinics. It can also be ordered by GPs for eligible identified individuals if catch-up clinics have been missed. So this slide walks through the eligibility for Beyfortus for this year's program, and you'll see there are 3 main groups. So the first of these is babies that are born on or after the 17th of March this year. So eligible infants are those that are born to mothers that did not receive Abrysvo, as well as babies that were born within the 2 weeks of the mother receiving Abrysvo. And also if the mother was immunosuppressed or lost maternal antibodies, such as through treatment with cardiopulmonary bypass or ECMO. And it also includes infants with risk conditions for severe RSV disease, regardless of whether the mother received Abrysvo during pregnancy. We'll touch again on those risk conditions on the next slide. The second group is the catch-up infants that were born between the time the 2024 program ended and this year's program started. So that's infants born between the 1st of October 2024 and the 17th of March this year. So this follows the 2024 Vulnerable Babies Program criteria, which is infants who are at risk of severe RSV disease. And that includes infants that weren't protected through maternal vaccination or didn't already receive a birth dose of Beyfortus, and that were either born at less than 37 weeks, Aboriginal or Torres Strait Islander, or have risk conditions for severe RSV. The third group there is infants and children who are up to 2 years of age that are entering into their second RSV season who have risk conditions for severe RSV disease. The risk conditions are shown here, which we've already covered tonight, so I won't step through those again, but they're just here for your reference. In terms of dosing, again, Beyfortus is available for infants who are under 5 kilos in that 0.5 ml 50 milligram dose given intramuscularly, and also available for infants over 5 kilos in a 1 ml 100 milligram dose, also given intramuscularly. And for all children who are entering their second RSV season, regardless of their weight, the recommended dose is 200 milligrams, given as those 2 1 ml injections, ideally at 2 different sites during the same visit, and preferably in separate limbs. So this table just summarises the ACT's 2025 RSV prevention program, showing the eligible groups for the 3 main RSV prevention products, with the 2 products that are included in the 2025 program being shown in green. So that's Abrysvo and Beyfortus. So Abrysvo is for pregnant women from 28 to 36 weeks gestation, and Beyfortus is for eligible infants and children who are under 2 years of age. There's lots of information on the ACT Health website regarding details for eligibility. So I'd really encourage you to look at those resources if you have any questions about whether an individual might be eligible for any of these products. With new products and with a growing immunisation schedule, there's always the potential for product administration errors. We have had some reports in the ACT and also in other jurisdictions of administration errors occurring. So before administering any product, remember to firstly check the Australian Immunisation Register for that individual, and that means you can check their personal details and see if they've already received that product, and it's also an opportunity to see if they're eligible for any other vaccines. So check that you've got the right person, the right product, the right time, and the right documentation. And to help prevent administration errors, you could also consider storing RSV products for different cohorts on separate shelves. And we also have stickers, such as shown on the bottom right of the screen there, and they're to help remind staff that only Abrysvo is to be used in pregnancy. And those stickers will be provided in the annual influenza packs. A reminder also to ensure that all encounters are entered into the air after the product is administered, and that's for all RSV products. So it's mandatory for Abrysvo, which is on the NIP, and Beyfortus can also be entered onto the air. We've mentioned the ACT Health resources, which you can see on the left of screen here, but there's also the Australian Immunisation Handbook, which has a chapter on RSV, which contains some excellent information. AESIs also has a lot of great information on RSV, which we've seen tonight, particularly their frequently asked question page, and also their clinical guidance on RSV immunisation product administration errors. And that page steps you through those various administration error types and what to do in terms of whether repeat dosing is required in the future. So take a look at those resources when you have the time, and particularly if you do encounter a RSV product administration error. So now we'll pivot over to the 2025 ACT influenza vaccine program. It can be interesting and it can be quite helpful to look back at what's happened during the previous year for influenza as we move into the start of this year's season. So we'll start with looking at the incidence of influenza in the ACT. So here you can see a graph that shows the number of influenza notifications over time, recognizing, of course, that this will represent only a subset of the total cases that occur, but the general curve still applies. So the x-axis here is showing weeks throughout the calendar year, and the y-axis is showing the number of notifications. In 2024, which is the green line, we can see a significant increase in the number of notified cases of influenza in the ACT compared to previous years. The increase in case numbers occurred at a similar time to previous years, excluding, of course, the earlier start to the season in 2022, which is that yellow line. In 2024, we reached a peak around June, and that continued out to about August before we saw notification numbers decline. There wasn't much of a prolonged tail, as had been seen in 2023, which is that blue line, and there wasn't a secondary rise at the end of the year, but there was a significant increase in notification numbers in the middle of 2024 compared to previous years. Similarly here, you can see there was an increase in the rate of influenza-like illness presentations to GPs in 2024 compared to previous years, and this is shown in the light blue dotted line on the graph. So this data was derived from ASPRIN, which is the Australian Sentinel Practices Research Network, and it's showing data that was collected on fever, cough, and fatigue. And it contains data from across Australia, including participating Sentinel GP sites in the ACT. So these higher rates of influenza-type symptoms throughout 2024 were also seen in data from flu tracking participants. If you're not already familiar with flu tracking, it's a surveillance system that was set up in 2006, which relies on participation from community members. Essentially, they send out weekly online survey via an email, and that asks about self-reported influenza-like symptoms. So if you're not already subscribed, I'd encourage you to take a look and consider registering with flu tracking to help them get some good population level data. But this graph from flu tracking is showing the percent of participants that reported fever and cough throughout the calendar year, with the national 2024 data shown in orange. So you can see that in 2024, there was a greater proportion of participants who reported fever and cough compared to 2023, which is that blue line. And the numbers for 2024 were similar to the 5-year national average. So let's take a look at what happened with influenza vaccination in the ACT in 2024. Based on the increased numbers of influenza and influenza-like illness reports, you might have already deduced that there was also a reduction in influenza vaccination. So the Vaccine Management Unit here in the ACT distributed over 110,000 NIP-funded influenza vaccines in 2024. Despite that, though, both ACT and national influenza vaccination rates were lower in every age cohort compared to 2023. The ACT rates are higher than the national rates, but they have dropped compared to previous years. These numbers are expected to be relatively accurate given the mandatory requirement to report influenza vaccines to the air as of February 2021. Specifically for Aboriginal and Torres Strait Islander people, we can see that the ACT vaccination rates were again higher than national rates, but there was a mixed picture in terms of changes from 2023 vaccination rates. So there was increased uptake in some cohorts, so the 6-month to less than 5-year cohort went up around 4%. The 15 to less than 50 and the 50 to less than 65 cohort went up by 1 and 2%, but vaccination rates were lower in 2024 compared to 2023 for 5 to less than 15-year-olds and also in the over 65-year-old cohort. And these rates in Aboriginal and Torres Strait Islander people were also notably less than the overall population rates for ACT in 2024, which is shown on the previous slide. So I just want to take this opportunity, given that, to reiterate the importance of documenting Aboriginal and Torres Strait Islander status at all clinical encounters, and also to ensure that it's documented in clinical software and also in an individual's AIR record. There's some really useful resources on the Australian Institute of Health and Welfare website about how to appropriately ask about whether an individual is of Aboriginal or Torres Strait Islander origin that you can refer to. In terms of provider type, there was a slight increase in 2024 in the proportion of influenza vaccinations being provided through pharmacies. That was up by 1.5% compared to 2023. But otherwise, it was quite similar across the board in terms of the proportion provided by GPs and other sites, including antenatal services and residential aged care facilities. So having seen what happened in 2024, we now come to the 2025 program, where we're hoping to see increased influenza vaccine uptake and fewer numbers of influenza notifications and presentations with influenza-like illness. So annual influenza vaccination continues to be recommended for all people who are over 6 months of age. The eligibility for free vaccination through the NIP is unchanged from previous years. So it covers children from 6 months to under 5 years, people who are 65 years of age and over, and specific populations that are at increased risk of severe influenza. And that includes Aboriginal and Torres Strait Islanders, pregnant people, and people with certain medical conditions. These conditions are shown in this table, and they're associated with an increased risk of influenza disease complications. And this one's taken straight from the AESIs statement on seasonal influenza vaccines for 2025, and it's unchanged from previous years as well. In the interest of time, I won't step through all the categories as they're shown in the table here, but again, I encourage you to be familiar with the eligible groups so that you're able to offer a funded vaccination to those individuals. Also, just to note that vaccination is recommended for other groups that are not NIP eligible, so that includes people that are obese, have chronic liver disease, those with harmful use of alcohol, and those with chromosomal abnormalities such as trisomy 21. This is another fantastic resource that many of you will be well acquainted with. It's another table from the AESIs statement which shows which seasonal influenza vaccines are available for particular age groups, and it shows you the age restrictions for the products. So the NIP funded groups are shown here in the white squares, and the ticks show the age groups which products are registered and available. The asterisk indicates that NIP funding is only for particular groups, so not all individuals in that age cohort. Compared to last year, you might notice that there's no Fluarix Tetra. Instead, for the 6 month to under 5 cohort, VaxiGroup Tetra is available through the NIP. And for the start of this season, stock of Flu Quadri will also be available through the NIP until stock of VaxiGroup Tetra is distributed. And we'll talk briefly about that on the next slide. A reminder that for individuals who are under 9 years of age, 2 doses are recommended in the first year of vaccination, which are given at least 4 weeks apart. So subsequent years only require a single annual dose, even if only 1 dose was given in that first year. There's no preferential recommendation between the use of Flucelvax Quad and standard dose egg-based influenza vaccines, and both can be given to people who have an egg allergy. For people who are over 65, the adjuvanted Fluad Quad and Fluzone High Dose Quad are equally preferred over standard influenza vaccines, but only Fluad Quad is NIP funded. Fluzone High Dose Quad is available on the private market. So as we've just seen on the last slide, these 4 influenza vaccines are funded through the NIP for eligible groups in 2025. Flu Quadri has been a late addition due to stock availability of VaxiGroup Tetra, so it's important to note that Flu Quadri packaging will not be labelled with the words Government Funded Program 2025 as it is for the other NIP influenza vaccines. So it's advised that providers make sure that Flu Quadri stock is identified and is only used and recorded as a NIP funded vaccine for children who are under 5 years. It is still available on the private market for all age groups. VaxiGroup Tetra stock is expected to arrive in early April. And this quick reference poster here will be distributed as part of the influenza provider packs, and you can request more from the vaccine management unit. The other graphic shown here, which can be useful, it's available on the Department of Health website, and it's another great way to see what products are available for particular cohorts. Also just noting that pharmacies in the NIP vaccinations in pharmacy program will be receiving Fluad Quad for use in individuals who are 65 years and over, and Flucelvax Quad for use in NIP eligible people between 5 and 64 years of age. In terms of the focus for influenza vaccination in 2025, the advice from the Chief Medical Officer is to promote influenza vaccination to eligible groups with a focus on improving uptake in children who are under 5, in First Nations people, and also in pregnant people. And this is particularly important given the decline we've seen in uptake of influenza vaccines in 2024. Resources from Sharing Knowledge about immunisation are available online, and they're really useful and practical evidence-based resources that can help when you're having discussions about vaccinations, including influenza. So take a look at those. It's also really important to remember that a recommendation to receive an influenza vaccine from a healthcare provider is known to be a strong predictor of a person's decision to vaccinate. So please do discuss this with individuals when you have an opportunity. A few things briefly about influenza vaccination in pregnancy. It continues to be recommended in every pregnancy at any stage. We've mentioned it can be safely administered at the same time as pertussis and Abrysvo or COVID-19 vaccines. And it's recommended to receive a 2025 influenza vaccine, even for those that have received the 2024 influenza vaccine earlier in their pregnancy. And if a person received an influenza vaccine before becoming pregnant, they should be revaccinated again during their pregnancy. Another reminder that it's mandatory to record pregnancy status at the time of administration in the air using either of the antenatal indicator or vaccine type fields. We mentioned this earlier, but the Australasian Society of Clinical Immunology and Allergy have advised that there is a very low risk of anaphylaxis with influenza vaccines in people that have an egg allergy. So if you do encounter someone with a history of anaphylaxis egg allergy, they are still recommended to be vaccinated with a full age-appropriate dose, but done so in a medical facility that can identify and treat anaphylaxis. And there's been no change in that recommendation from previous years. In terms of accessing seasonal influenza vaccines, the ACT Vaccine Management Unit will be rolling out more than 50,000 doses of NIP-funded influenza vaccines to over 200 providers. And stock is anticipated from early April. And providers will be receiving a base stock and are then able to order more online, or you can wait until the next scheduled delivery. At any influenza vaccination encounter, there might be an opportunity to discuss other vaccines that an individual is eligible for, and that includes COVID-19 vaccines. The 2025 ATAGI COVID-19 vaccine recommendations were released just last week, and messaging from that document outlines the continued importance of protecting people that are at risk of severe disease from COVID-19 infection. So the current vaccines available are Comirnaty JN1 and Omicron XBB.1.5, and they can be co-administered with any other vaccine for people who are over 5 years, including influenza vaccines. In terms of a primary course, a single dose is recommended for people who are over 18 years, and 2 or 3 doses are recommended for individuals who are 6 months to 18 years that have risk factors or severe immunocompromise. The ATAGI recommendations for booster doses are shown in the table here. So 6-monthly vaccination is recommended for people who are 75 years and over, and for the 65 to 74-year-olds, the recommendation is that vaccination for every 12 months. And it's also recommended every 12 months for people who are 18 to 64 years with severe immunocompromise. Other vaccines to think about include vaccines for pneumococcal, so Prevnar 13 and Pneumovax 23 for individuals who are 70 years and over, for First Nations people who are 50 years and over, and for immunocompromised people who are 18 years and over with eligible conditions. Vaccination against shingles with Shingrix is also available through a 2-dose course, and that's 2 to 6 months apart for immunocompetent people and 1 to 2 months apart for immunocompromised individuals. And the eligibility conditions are outlined in the Australian Immunisation Handbook. We touched on this earlier, but there's also RSV vaccines available privately for individuals who are over 60 years of age. So Arexvy and Abrysvo are approved for individuals who are 60 years and over, but they are recommended by ATAGI for people who are over 75 years or people who are 60 years and over that are Aboriginal and Torres Strait Islander or that have medical conditions that increase their risk of severe RSV disease. As we know, adverse events following immunisation can occur after vaccination, and they are notifiable in the ACT. You don't need to be certain that a vaccine has caused an adverse event. You just need to be suspicious. So if you do suspect that a vaccine could have contributed, it's quick and it's easy to report using the online form, or you can call or email or fax using the details that are provided there. If it's of interest to you and you need some CPD points, there's also a learning module on adverse event reporting that's available online, and it covers the why, the what, and the how of reporting an adverse event. So take a look at that if it's of interest. Heading into winter, it's also a timely reminder of ACT Health's winter wellness messaging. So as we know, respiratory viruses are more than just a cold. They can cause severe disease and death. We're all aware of the importance of vaccination. It's a safe and it's an effective way to protect our communities from respiratory illnesses. And vaccination is, of course, one way to be prepared before we get sick, but it's important particularly for individuals who are at high risk of severe illness to speak to their primary care team and to have a plan if they become unwell. The role of testing, of course, is also very important to both confirm a diagnosis and help to guide management, and it also adds to surveillance of respiratory infections. So take-home messages for today. Firstly, for the 2025 RSV prevention program, there are 2 available products. There's Abrysvo, which is recommended for pregnant people between 28 and 36 weeks gestation, and Beyfortus, which is for eligible infants and young children. A reminder again to take a look at the ACT Health resources for eligibility guidelines. Reporting to the air is recommended for all products, including Beyfortus, and it's mandatory for Abrysvo as it's on the NIP. And it's also mandatory to report pregnancy status at the time of vaccination. A reminder also that both Abrysvo and Beyfortus can be safely co-administered, so Abrysvo with other vaccines during pregnancy and Beyfortus with vaccines for infants and for young children. For this year's influenza program, influenza vaccines are recommended for all people who are over 6 months of age, and they're NIP funded for specific cohorts. All influenza vaccines, both through the NIP and privately, as well as pregnancy status at the time of vaccination, must be recorded in the air. And do consider opportunistic vaccination when you're seeing patients, including with COVID-19 vaccines, pneumococcal, Shingrix, and RSV vaccines. There's some useful resources listed here for future reference. These ones are specifically for RSV, and there are ones for influenza and immunisation in general. Thanks so much for your time. I'll hand back over to Leonie.
Sorry about that. I was having problems with my microphone. Thank you very much, Megan. So the questions are starting to roll in. So that's great. So I will start picking on presenters. But before I do, just a reminder to fill out the evaluation survey, and also you're able to report CPD hours for this event. Usually it's about 1.5 hours, but judging by the questions, it might be even longer. If we don't get to your questions, please email immunisation@act.gov.au and they will be able to answer your questions. And we'll put up the YouTube recording in a couple of weeks of this webinar. So now on to the questions. Oops, hold on. Sorry, I'm just being, there we go. Okay, so the first question we had, I think probably is for you, Jean. So if parents wish to pay for Beyfortus privately, do you encourage this, or are you ambivalent about it if the mother has already had Abrysvo in pregnancy?
The first thing that I'd like to say is I'm not aware that nirsevimab is available on the private market. So I think that'll be the first issue we're considering it privately. The second issue is that if if a mother has been appropriately vaccinated, as you said, that she there should be a good level of antibodies which are transferred to the baby and will provide them with good protection for that first 6 months of life. So there shouldn't be a need to, to have nirsevimab on top of the vaccine in babies who are standard risk. And there's no, I mean, there haven't been studies conducted which have looked at, standard risk babies whose mother has already been vaccinated receiving nirsevimab on top of that. So, whether how much extra protection you actually get on top of a maternal vaccine is unknown. So I think at this stage, the issue obviously will be, that I don't think you can obtain nirsevimab on the private market, but even then, I don't think that it should be required for most children.
Right. Could I just quickly, thank you for that. I can see lots of people are starting to type questions into the chat box. Could they paste their questions into the Q&A box, because we won't be looking at the chat box today. So there's another question related to that, Jean, and it's if the mother didn't get the RSV vaccine and would like the baby to have the Beyfortus, but the baby is too old, can the baby still get one? And I think you've just answered that.
Yeah, and the only other thing that I'd like to say is, like that graph where I showed where the hospitalization risk is, the severe disease, it's predominantly the very young infants. So I know we talk about 6 months, but it's even in that first 3 months of life, So once we get over 6 months of age, if you don't have a risk condition, then the risk of severe disease is progressively getting smaller and smaller, So the need for it and the benefit from Beyfortus may be much less in those older children who don't have a risk condition.
And now there's a flu question, so I think it's your turn, Megan. So are pharmacists provided with government-funded flu injections for all age groups?
Thanks, Leonie. Pharmacists are provided with influenza vaccines for over 5-year-olds. So they receive the NIP vaccine, Fluad Quad, for over 65-year-olds, and they're receiving Flucelvax Quad for eligible NIP funded individuals who are over 5 years of age.
Right. And now, when will Abrivzo be made available under the NIP through community pharmacy?
Leonie, I might take that.
Yeah, this is Alison. She's from ACT Health as well.
Hi, thanks everyone. I'm Alison Kingsbury. I'm the Senior Director for Immunisation. We're currently working through the pharmacy vaccination standards, which will be amended hopefully in the next couple of weeks. And one of those recommendations is to add Abrivzo for pregnant women to enable pharmacists to do that. So ACT Health will let you know as soon as that's happened and when you can start ordering.
So another one for you, Jean. So if a pregnant lady accidentally gets 2 Abrivzo doses from 28 to 36 weeks, is there a risk? Obviously, an adverse event needs to be filled out and ACT Health needs to be notified, but is there any risk to the pregnant woman or to the baby? Jean? I think Sean's frozen. Megan, would you know the answers for that one?
I'm not sure if it's just me or
I think your connection's frozen, Jean. So if you're happy, Megan, are you able to answer that question?
I'm so sorry. Could you ask it just again, please?
Sorry. If a pregnant lady accidentally gets 2 Abrivzo doses from 28 to 36 weeks, apart from reporting it, obviously, as an adverse event, is there anything else that needs to be done? Is there a risk to the pregnant woman or to the fetus or the baby?
I think something like this is actually quite useful to refer to the NC's resources where they've got their vaccine product administration areas where it talks you through examples such as this and what you need to do and what you should be monitoring for. My understanding is that in this particular instance, there isn't anything particular that we're aware of in relation to an adverse event to monitor for, but important to report it through to the ACT immunisation section if that's occurring here, and to follow the guidance, the latest guidance that's in that NCEARS resource.
Thanks. Now, this is an important one because we often have people in GP land who we're saying, is it severe asthma or is it moderate asthma? So the question is, can you define what is severe asthma for the free flu vaccinations? And the question is, I often have patients arguing that they have asthma and the flu vaccine should be free for them. If the patient is on Symbicort 106, 2 puffs as needed, is that severe asthma as it's a combination of 2 medications in the inhaler? And that one will be for Megan. Hi, Jean. Yeah.
It's a good question. I suppose the thing that it all comes down to is your clinical decision as to whether you think that patient meets the definition of severe asthma and if you think they would benefit. I mean, obviously the recommendation is for all individuals to receive influenza vaccination when they're over 6 months of age. And if you think that based on your clinical assessment of that patient that they fit that criteria, then they should receive an NIP funded one.
Yeah, I think that the underlying message from the influenza talk is vaccinate, 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 isn't it? So the next question, is there any move to allow practice nurses to be paid for administering vaccines in the same way pharmacists are without the need for the doctor to see the patient? So I think that they can do the COVID vaccination as long as there's a GP present in the surgery, but I'm not sure about the other vaccinations.
So Leonie, I'm happy to take that. And it's a bit of a hospital pass, but I'm going to pass it on to the Commonwealth. That relates to the MBS, and there's a lot of discussion whenever I go to a national meeting about that. But to my knowledge, not at the moment.
Okay, so watch this space. Yep. And given the high rates of influenza notifications so far this year, should we be encouraging earlier influenza vaccination as soon as possible, or is it still recommended to wait a few weeks, say to the end of April, early May, to catch that June to August peak? Yes, so again, Megan, you're on this one.
Yeah. Well, with influenza vaccination, the recommended timing to receive it is before the start of the influenza season. And yes, that is typically May to June in Australia, but the timing of that peak activity can change each year. So it is recommended to get the vaccine as soon as it becomes available, which will be from mid-April. So any time from once it's available.
The government stock is about to hit the shelves. Yep. And a question about Shingrix being administered with other vaccines. I think there was one concern about Shingrix being administered with Fluad. Was that correct? There was a concern about a flu vaccine and Shingrix together.
Yeah. The latest recommendations that I've seen in the Australian Immunisation Handbook say that Shingrix can be safely co-administered with other vaccine products, but noting that if it is administered at the same time as another vaccine, there is an increased risk of local reactions, given the reactogenicity of both products, particularly if you're giving 2 adjuvanted vaccines. But unless there's anything, Dr. Jean, that you wanted to add.
No, I was going to say exactly the same thing. You know, they are 2 adjuvanted vaccines, and adjuvanted vaccines sometimes have slightly higher reaction rates, and you know it is acceptable to co-administer them, and you know, it's just being wary of the fact that there might be a slightly higher rate of some adverse events like a sore arm.
Is that something you need to specifically warn patients having those 2 together? That could be, you know, there's a risk of that, or would you just recommend that they, or listen to them if they want to take them apart, or would you just administer them?
No, I think whenever you're co-administering vaccines, you know, the general advice you can give is that there might be a slightly higher rate of some, you know, local or systemic adverse events, and I think you know, patients are free to choose to have them separately. They just need to come back for a second visit, and as a provider or a GP, you just need to weigh up, if the patient's going to come back, so that's why we sometimes look at opportunistic vaccination or giving multiple vaccines at the same time, just to be able to get, all the vaccines in on one occasion. So sometimes doing that and putting up with a slightly higher rate of adverse events is worth it to be able to offer that protection.
Okay, another one for you, Jean, because you're offline for a tiny bit. So for 65 years plus, a Brisvo or a Rexvi?
Yeah, I mean, the truth is, there's been some early studies now that have looked at some, real world vaccine effectiveness for both vaccines, and they are very, very similar, So I think the current recommendations in the Australian Immunisation Handbook are that both of them are appropriate, and there's no preference for either vaccine.
I have another question. I have heard from a couple of people there is a private flu vaccine which gives better results. This includes a 70-year-old couple. Are you aware of that one, Megan?
No, I'm not aware specifically of what product they're talking about.
Would that be Fluzone? The high dose flu, I think there was a Fluzone.
If it is that, so
Yeah.
Fluzone High Dose Quad and Fluad Quad are both recommended for over 65-year-olds, but they're not preferentially recommended one over the other.
If a parent declines the monoclonal antibody for their infants, if the infant is eligible, is there any form you need to fill in? And will this be a barrier to enter school in the future? So, Jean, that one's for you.
I guess that's more of a program question. So, I mean, I'm not aware of any forms. So, it's and I'm not sure how that will affect in the future. But really, it's the monoclonal antibody really is about protecting the individual. So it's different to some of the other vaccines which are used where we're looking at protecting against transmission. So most of the RSV products have not been examined for how well they prevent infection or prevent transmission to others. So it's more about individual protection. So if you look at it that way, then I don't. And it's really the protection's in the first 6 months of life. So it's not about protection at a later date. So I'm not aware of any forms at this stage.
Leonie, do you want me to answer that from an ACT perspective?
Yeah, that would be great, Alison. Thanks.
So we need to know if a child has been vaccinated before they start school. But as Jean says, they're 5 by the time they're starting school. So the fact is that if they have nirsevimab, the effects of that are going to be well gone. But there's actually no, each state and territory has a different policy on no jab, no play, etc. So yeah, it's not going to be an issue at the moment.
Okay, this one's about the flu again, so over to you, Megan. Is the influenza vaccine this year targeting the circulating vaccine strain that's just passed through America and Asia during their recent winter?
That's a good question. I'm not certain of whether the current strains match the Northern Hemisphere strains that were just seen in their most recent winter season. And it's always hard to predict what strains are going to be circulating here in Australia in our season. And they're quadrivalent influenza vaccines again this year. And yeah, it's difficult to say it's going to specifically cover what we see. We just sort of have to hope that the product that's being created, which is based on best evidence from the previous season, will align with what we see through the coverage in Australia.
And another one, how about administration of Shingrix when patients are also on immunomodulatory treatments? Do they need to have a gap between the injections? I think that was already mentioned, that you said for immunocompromised people, 1 to 2 months between the injections. And we're not sure if people need boosters on top of the 2-dose schedule, are we? that hasn't come, advice on that hasn't come out.
No, not that I'm aware of.
Yeah.
No, I mean the evidence has, you know, that they have had clinical trials of Shingrix in immunocompromised people, and usually the 2-dose schedule confers good protection. You know, they've done trials in quite significantly immunocompromised people with stem cell transplants, etc. And you know, with the 2-dose schedule, it's a very immunogenic vaccine, and it does lead to good levels of protection.
Is it cheeky to ask a question about measles? So we have a question about measles cases in people returning from Vietnam, and if that's been seen in the ACT like it was seen in New South Wales. Are you happy to answer that, or would that be more that we'd like you to send that one to the immunisation at act.gov.au?
Is that directed to
it's not to you.
Okay.
It's to either Megan or to Alison.
Look, Leonie, I think if that person wants to write in to us, we'll hand it over to the surveillance team.
Sure.
To my knowledge, we haven't had any measles cases here. My advice is to check your immunisation status and talk to your primary care provider if you're concerned.
Right. So we've got one more question. We've got some questions also in the chat box. So would you be happy to hear about them, or are you wanting to wind it up? Megan, Alice.
I think if we've got a lot of questions, what we might do, because we probably won't get to them all tonight, is we'll take a bit of a summary, and we can follow up with people either through the Capital Health Network or through us directly.
Okay. Yeah. So the last question in the Q&A box is, if someone had just caught influenza A/B virus confirmed on rat, when should they get the influenza vaccine in 2025?
The recommendation in the AIH is for an individual to have time to sufficiently recover from a current influenza vaccine, influenza infection, but then should go on to receive the current season influenza vaccine when they're much better, so that they're able to continue to have protection against possible other strains that they haven't been exposed to so far this year.
Yeah, that makes sense. Okay, well, that's we've got through the Q&A box. So the chat box will forward on to ACT Health for them to follow up after the webinar. I just want to thank all the speakers and the panelists so much for all your information. It's been really, really useful, and it's really good to get some clear guidance on the RSV vaccine and who to use it on and when. And I'm sure the audience really appreciates all the time and effort you've gone into for creating your presentations and speaking to us tonight. So thank you very much. And we'll say goodbye. Good night.
Thanks, Leonie.
Thanks.